Hello, everyone. Welcome to our industry showcase, $73.8 million in annual financial benefits by redirecting ED visits and economic study results. Today on February 11th, 2025. My name is Melissa Haddad, and I'll be hosting you today. I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We gratefully acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse nations, First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by the Treaty 13, signed with the Mississaugas of the Credit, and Williams treaties signed with the multiple Mississaugas and Chippewa bands. Please take a moment to share in the chat the territory you are joining from. On a technical note, please use the chat or Q&A if you are having any technical difficulties, and I will be happy to help you out. We will also have time for Q&A, so please submit your questions at any time, and we will get to them at the end of the presentation. Today's industry showcase is brought to you by Petal. Thank you very much for sponsoring the session and bringing together this thoughtful discussion. It is my pleasure to introduce our presenters. Marie-Hélène Lefleur specializes in the application of biostatics and economics to health economics and outcomes research. She brings an extensive experience in analyzing retrospective databases, including medical claims, electronic health records, and clinical trial data, as well as the design of chart review studies. Her expertise also extends to economic modeling, such as cost effectiveness and budget impact models, as well as systematic literature in reviews, including meta-analysis. Elliot Desailly has over 10 years of experience working with healthcare systems across Canada and United States. He is currently at the Director of Business Development Public Sector, Western and Atlantic Canada, for Petal Health, where he supports and leads engagements with stakeholders across Canada's healthcare system related to improving access to care. Elliot has also serves as a member of the Board of Directors for HIMSS Prairies chapter and is an active member of Digital Health Canada. Thank you for coming today. I will now pass the mic over to you, Elliot.
Where we've helped reduce emergency department overcrowding, but more importantly, to talk about how that entire process unfolded and how a partnership was formed between the ministry and our organization. A little bit about me and my background. So I've been with Petal for close to 4 years now, and I've seen firsthand the power of collaboration between the public sector and the vendor community. Our mission at Petal Health is to improve access to care. We live and breathe this every single day. As someone who works in healthcare, among many others on this call today, we're also patients. So we can really speak from our experiences and understand the challenges that other patients face in terms of accessing, basic services such as primary care. And it's really our responsibility to really understand how can we solve those challenges through technology, through partnerships, and through general understandings. So today, we are presenting a case example of how digital innovation can have a major impact in the efficiency of the healthcare system. Let's see if this is going to move forward. There we go. So since 2020, Petal has collaborated with Quebec's Ministry of Health to streamline processes and have helped reduce over 800 emergency department visits per day across the province. An economic study has shown that this decrease in ED reliance is annually saving the province over $73 million, and the results of the study will be reviewed in depth later on in the presentation. Our goals today will really have a conversation about how the province of Quebec reached this point. Our objectives are first to review the Ministry of Health's challenges that require solutions. So what are the challenges of ED overcrowding and the potential financial impacts of its overutilization? Then we'll talk about how Petal's technology enabled some of these transformations across primary care. through the partnership between the Ministry of Health and Petal. And finally, we'll dive into the details of the economic study to show how reducing the reliance on emergency departments has resulted in financial benefits for the province. I'm now going to pass over to Marie-Hélène to discuss the challenges of ED overcrowding and the financial impacts associated with overutilization.
Thank you, Elliot. So the first portion of the presentation will focus on what's the challenge that the Ministry of Health wanted to address and what is overcrowding in the ED sector. So overcrowding is characterized by an imbalance between supply and demand. So that means that the patient demand for ED services is higher than the hospital beds available or the number of patients the healthcare workforce can take care of at a particular time. And when this happens, the performance of the ED is compromised. It means longer waiting times and just inefficiencies in the system. This imbalance can occur for various reasons. For example, the patient demand is highly seasonal, very higher in the winter, especially right now, lower in the summer. But another important factor of ED overcrowding in general is the use of ED for non-urgent cases. In Canada, around 33% of emergency department visits are identified as non-urgent issues. In Quebec, the Ministry of Health has identified this figure to be as high as 50%. And the situation is really not ideal from an efficiency perspective. ED are structured to take care of urgent medical problems. They're not structured to take care of non-urgent medical problems efficiently. And this leads to economic impact. Using ED for non-urgent cases is considered one of the most costly and avoidable factors contributing to the persistent rise in healthcare costs. And why? Because the cost of an ED visit is high and is increasing too. The cost of an ED visit has almost doubled between 2005 and 2022. The direct cost is $96 has increased to $187 in 2022-2023. But that's just the direct cost. When we take into consideration the cost of triage, the administrative costs, and all other costs associated with being in an ED facility, the cost of a visit is $361 per visit. The other pressure that ED overcrowding adds to the system goes through overtime. So this figure here shows two things. First, that the proportion of hospital hours worked in overtime is increasing. So year after year, there's more and more hours that are worked in overtime. But the second thing that this figure is showing is that the emergency department uses as much, almost or more than twice as much overtime than the other departments in the hospital. So that really speaks to the fact that more pressure in the ED cause more overtime and then has economic impact of that. And the efficiency of the emergency department is really seen as an indicator of the general health of a healthcare system, because the ED is often the last resort for obtaining medical care. If patients cannot get access to primary care, then they will end up in the ED. So ED overcrowding is seen as a signal that other parts of the healthcare system might not be working properly. And this is really the challenge that the Quebec's Ministry of Health needed to address. And then I'll turn it back to Elliot to go over what was the partnership between Petal and Ministry of Health of Quebec.
All right, thank you for that, Marie-Hélène. So for this portion, it's really talking about how this partnership originated and how Petal's technology really enabled to streamline processes to improve access to care through various programs. Obviously, today's discussion is focused on the ED redirection initiative, but there's other programs in terms of timely access and primary care access points that follow a very similar pattern that has really been enabled through our Healthcare Orchestration Platform. So beginning at the start, the slide goes. There we go. So the partnership really originated from the Ministry of Health's lack of visibility on the healthcare system and a need for connection between all systems to drive meaningful initiatives. This is when a partnership between the Ministry of Health and Petal was established. So we're all aware that our healthcare system is fragmented by silos, which increases administrative burdens, complexity in patient navigation, and challenges associated with improving processes that could advance overall efficiency. This isn't common knowledge. This has been occurring more and more often over the years as technology has advanced and more digital tools have become available for patients, for providers, and for health systems. Petal created, so Petal created a centralized digital layer called the Healthcare Orchestration Platform. What is healthcare orchestration? So in simple terms, it's connecting the demand for patient care with the physical supply. And I'll use a reference to help make this as clear as possible. So in the travel industry, it's something that we're all aware of and that we've probably experienced a few times within our lifetimes. I'm looking to book a hotel room. I have many different entry points to book that hotel room. I can call the hotel directly. I can book online through their website. I can use an aggregator such as Expedia or Booking.com. I could even call a travel agent to book it for me. So there's a lot of different entry points to try and book this one specific hotel room. On the other end, on the supply side, this hotel room is within a hotel itself. So it's one specific room. How am I able to book, room 1135 in downtown Winnipeg and secure that spot for myself? There's a technology that exists in the middle. So it's an orchestration layer that really aligns all those different demands and focuses on a single availability on the supply side. The same can occur in healthcare and has occurred, which we'll be discussing later on today. In healthcare, there are many demands. We could argue that patients have more access than they've ever had before, but these accesses are fragmented across the ecosystem. Patients can book online, they can call their clinic, they can call 811, they can call call centers, they can go through a digital front door, they can access virtual care services, and if worse comes to worse, they can access the emergency departments for frontline care. So many different access points, but they're fragmented across the ecosystem. So in terms of patient navigation, it's very challenging for patients to find the right appointment with the right provider. On the supply side, this already exists. Supply is ingrained within EMRs, EHRs, other scheduling solutions. It's really about the appointments that they provide and finding the availabilities. So Petal's healthcare orchestration platform aligns all of those different service points, all of those different demands with the physical supply that currently exists in silos. So by aggregating the available appointments and the availabilities, we're able to really push and identify all of the available space and making it open to patients. And that's really where we've seen a transformative impact in terms of access to care. So if we look at the example of reducing emergency department visits in Quebec, Petal began by centralizing the province's primary care system. We connected with over 800 primary care clinics, and on the supply end, integrated with the various EMRs within the province. On the demand side, we integrated with the booking portals, both private and public, as well as other service points, such as 811 and emergency departments directly. In order to make all this work, we also had to integrate with the provincial validation systems. Understanding who is the patient, so through their health identification number, who is a provider through the provider registry, and attachment, whether they're attached or unattached. Now, I mentioned, creating a connected health system and how important it is to function in real time, but there's other benefits to integrating with the digital layer. One of them being change management. So we all work in healthcare. We understand change can be scary. It's often a roadblock in a lot of conversations because there is risk involved. And when you work in healthcare, risk is always top of mind. So the less change management that you can do is often seen as a better alternative to, say, disruptive innovation. So the healthcare orchestration problem really limits the change management for providers, for patients, and for health systems. So let's start with the providers. They use multiple tools throughout their days. They're bombarded on a daily basis with new technology, how this can make your practice more efficient. Really, what the healthcare orchestration platform does, there's no change management. Physicians can continue using their EMRs, their online booking portals, their form management, reminders, and whatever tools that they have. So on their end, they see no change to their practice. For patients, we're in a similar boat. We have many different tools that we can use to access care. And oftentimes, we don't want to learn to use a new online booking portal or trying to remember a new password that has to be reset every 30 to 60 days. So for patients, once again, their experience is the same, apart from now there's more availability, there's more appointments that they didn't realize they had before. And for the healthcare system, this technology leverages previous investments in health IT. And we know over the last 15 to 20 years, there have been significant investments in healthcare IT to digitize our healthcare system. What this really translates to is rapid scalability and the ability to leverage those investments and really maximize their use. So once we created this primary care ecosystem, we were then able to start to streamline processes in real time throughout primary care in Quebec. So we worked on many different processes that support the reduction in emergency department visits. 3 ministerial initiatives were identified. The first is ED redirection, which aim to reduce the reliance on emergency services by encouraging patients to seek appropriate care outside the emergency department and redirecting them to nearby primary care facilities. The second initiative is the primary care access point, which aim to provide services to unattached patients, for unattached and collectively attached patients across the province. So through this program, clinics received incentives to take on unattached patients or patients who are collectively registered within a clinic. So collectively attached patients are also referred to as clinic-based attachment. So it's a patient I'm not attached to an individual provider or a team of providers, but the clinic itself. And the final initiative was called timely access. And this was designed to ensure that patients can quickly access care. However, this initiative was dedicated specifically to attached patients who require urgent or semi-urgent care. This initiative defined a timely visit as one where an appointment can be taken within 36 to 72 hours prior to the consultation. These initiatives were then regrouped into 2 main categories, or 2 main processes. First being ED redirection. So through the Healthcare Orchestration Platform, triage nurses can offer to schedule appointments for less or non-urgent patients. So in this context, CTAS 4 and 5 from the emergency department with available primary care providers in the region. So in this context, as a patient, the ED is my last resort if I'm seeking primary care, but perhaps I'm not able to see my primary care provider because I'm attached, I'm using the last resort, or if I'm an unattached patient, I have nowhere else to go. So I end up in the ED with, perhaps a non-urgent condition. So once I show up to the ED, I get triage as I normally would. And as a caveat, Petal's responsible for the technology portion and not the triage process. So that's the responsibility of the hospital and their normal process that they have when a patient reaches the front door. The difference in this context is the patient is given the option to either, you want to wait for 12, 15 hours or whatever the time length is, or because we've connected the entire primary care ecosystem, we're able to find you an appointment, down the street, nearby your house, nearby work, within the next X amount of hours. So we call this point of care redirection. The second ED reduction process was through online patient booking. This enables patients with or without a primary care provider to find online different types of appointments with physicians, NPs, or any other healthcare professional, either independently, so on their own, or with assistance from Health 811. So this process is really upstream redirection and is very similar to point of care. In the upstream use case, patients are calling 811, their identity is validated, their attachment or unattachment is validated, and once again, they're triaged by normal processes by the healthcare professional on the other line. And because of visibility into all available appointments within that region, in that city or locality, they're offered the ability to schedule an appointment with a primary care provider and not directed to go to the ED or go try a walk-in. So there is a tangible result out of the upstream redirection process. I'm now going to further describe the underlying processes that are aligned with the ministerial initiatives. Oh. Did we move ahead? There we go. We're good here. So for the ED redirection, as I mentioned, this is for both attached or unattached patients. I know there's been a lot of conversations across jurisdictions about increase in attachment and how that is a priority to ensure that all patients are attached to a primary care provider, whether it's a physician, a nurse practitioner, or team-based care. But the one thing to always remember is attachment doesn't necessarily mean access. You still have attached patients who aren't able to access timely care that end up at the front doors of emergency departments. So this initiative and through the processes allows for both attached and unattached patients to be redirected to primary care facilities after they've been triaged. The online patient booking, there's two distinct processes on whether a patient is attached or unattached. So unattached patients are guided to availabilities through the primary care access point initiative, and attached patients are directed to availabilities through the timely access initiative. This is made possible through our integration with the provincial assets that determines a patient's identity and their attachment status that helps place them within the appropriate process. So in all three use cases, they follow a similar pattern. We're capturing the patient demand and we're aligning it with the true physical supply. So that is a repeatable process, whether it's primary care, mental health, vaccinations. There's a lot of other use cases, but really, I guess, the core ingredient, the special sauce, how it works is the processes in between and really finding the right appointment with the right provider at the right time for the right patient. So moving on, I will pass the mic off to Marie-Hélène to talk about the results of the economic impact assessment.
Thank you, Elliot. So at the beginning of the presentation, Elliot mentioned that the partnership has successfully reduced reliance on ED by more than 800 visits per day, and that translates in economic benefit equivalent to $73.8 million. So this is what we'll go over in the next portion of this presentation. So Petal reached out to us at Analysis Group to conduct an independent economic analysis of the direct benefits of the real-time orchestration platform implemented in the province of Quebec. So really the objective was to evaluate the economic benefit associated with the implementation of the platform from the angle of reduced reliance on emergency services. A standard way to evaluate the impact of a change is to use the information before and after the change to be able to project what would have been the outcome with or without the change being implemented. In the context of this study, which time frame we should be looking at? So the platform has been implemented in 2020. So for the period before, we used the full year before the pandemic, very thought decision here, from April 2018 through March 2019. And the period before, we used the latest complete year at the time the study was conducted, which is April 2022 through March 2023. And as presented by Iliad, the partnership between the Ministry of Health and Petal allowed the implementation of two main processes through which it was hoped that we could reduce reliance on ED. So for the ED redirection process, as mentioned again before, the idea is that patients present themselves to the ED, they go to the triage, and then they are redirected to a visit in a primary care facility. So how would we be able to evaluate the impact of this process? So the impact we wanted to look at is directly the number of redirected ED visits before and after the implementation of the platform. From the second process, the online patient booking, where patients are able to book an appointment directly themselves or through the help of 811, but directly in the primary care facility. Then the impact of this, we thought what we want to see or what we would envision is that this would have an impact on the total number of ED visits in the province. So the impact that we wanted to look at is the total number of ED visits. To be able to obtain those numbers, what we did is that we sent a request for freedom of information from the Ministry of Health. And we requested the exact two numbers that are presented here. So, and for the total number of redirected ED visits, again, we wanted to obtain the numbers before and after to be able to see whether there was any additional redirected visits that happened after the implementation of the platform versus before. From the total number of ED visits, what we wanted to look at is there any avoided visits now that the platform is implemented? So the number that we needed to obtain for this was really the number of total ED visits in the period before and the period after the implementation. So this was really the main data that we used for the analysis. The other portion is the cost. As we've seen at the beginning, a cost of an ED visit is $361 per visit. And this is higher than a cost to a clinic visit, which is $71.21 per visit. When we think about the ED redirections, those patients who go to the ED and have go through the triage and then end up in a primary care facility, the cost, we have to take that into consideration, the cost of the triage, which is $134. So for the ED redirected patients who go to the triage and then go to the clinic, the cost of their visits is $205, which is still smaller than the original $361 for each ED visit. So these are the numbers, the financial, the cost numbers that we will be using for the economic model. Starting from the redirected ED visit. When we received the numbers from the Ministry of Health, they were exactly those. So what we were able to observe is, yes, there was some redirection originally happening before. This was mainly when hospitals were associated with one or two nearby clinic. But after the number of redirected visits has increased by 118,000 visits. And we thought that this was directly could be made possible because of the platform, the fact that now nurses, triage nurses have access to the entire ecosystem and are able to find appointments for those patients through primary care clinics. So the total redirected ED visit attributable to the platform is evaluated to the 118,000 visits. And what that means in terms of costs. So without the partnership, those visits would have been completed in the ED setting. At a cost of $361 for each of these visits, the total costs of these avoided visits or redirected visits, would have been $42.7 million. But with the partnership, those visits incur a cost of $200. And that's, again, the triage cost and the cost of the clinic visit. And these visits now, with the partnership, totaled $24 million. The difference between the two is what we consider the economic benefit from redirected ED visits, which is $18.4 million. So this is the economic benefit that we can evaluate from the redirected ED visits. If we do the same exercise for the total avoided ED visits. So here again, going back to the request of information to the Ministry of Health, the numbers that we obtained were very interesting. And I should say that I was personally a bit surprised when I saw them, pleasantly surprised. In the period before, the number of ED visits was 3.7 million. But after, so 4 years after, the number of ED visits has really decreased to 3.6 million visits for that year. So that represents a difference of 100,000 visits. But the population has grown between those two. If we think about it, so what we did is think about the number of visits per capita. So for each person in the province, before it was 0.44, now 0.41. So with more people, we still have we still in the period after there were fewer ED visits than before with less people. So when we think about what would have been the total number of ED visits without the partnership, so we thought that the number of visits per capita is really the number that we should take into consideration. Without the partnership, because of the adjusting for the population growth in Quebec, the number of ED visits would have been 3.8 million visits compared to the 3.6 million. So here the difference is 250,000 of visits that are avoided in the period after with the partnership, if we compare to without the partnership. But that number is really large, and we really wanted to be conservative and to think about, do we really believe that number, that reduction in ED visits is solely due to the implementation of the platform? So what we did is we circulated a little bit the numbers. We socialized it and with the Ministry of Health and with clinicians, and everyone really agreed that without that platform, without that innovation, these numbers would not have been possible. But then thinking a little bit more about it, we realized that even if the period after starts in April of 2022, one of the main effect of the platform, of the implementation of the technology, the primary care access point initiative, was really implemented maybe just in July of 2022. So we thought, let's be conservative and let's not take the full 254,000 visits. Let's take just 3/4 of it to be attributable to the platform, because maybe there's other things that happened, and one of it is that the GAP, or the primary care access point initiative, was not fully in place for the entire period. So doing this, then what we can attribute to the platform implementation is that 191,000 visits were avoided, ED visits were avoided. Now let's turn into the cost story. So without the partnership, it's thought that these visits would have occurred in the ED setting, totaling a cost of $69 million. With the partnership, those visits are seen in the primary care sector at $71 per visit, totaling $13.6 million. So again, the economic benefit that we can obtain here is in the difference between those two numbers, which is $55.4 million economic benefit from avoided ED visits. And it's when we sum the economic benefit from the avoided ED visits, so the $55 million, with the economic benefits from the redirected ED visits of $18.4 million, that we end up with the $73.8 million per year in economic benefit associated with the reduction of reliance on ED following the implementation of the platform. So this really is the main finding of this economic study when we talk about the direct economic benefits. But thinking about it, there's a lot more additional benefits that can be considered or that should be considered with this better access to primary care. The first one is just improved ED efficiency. If nurse staff have less people to take care of, that means because people are just redirected elsewhere, that means that they have more time to spend with the patient. And that has been demonstrated to improve the quality of care of patients, staff satisfaction, and just helps the ED to be more efficient in general. The other aspect that we can think of is the ED waiting times. If there's fewer people in the ED setting, those who stay in the ED and need to be in the ED because they have urgent medical problems will wait less. So their waiting time will be shorter. And that has been demonstrated to be associated with reduced healthcare costs in general. Yeah. The other aspect that we're all very familiar with now is infection risks. If there's more people in the ED, in the waiting rooms, that increases the risk of infections. And this adds a lot of pressure in the hospital system if there's more infections. These were kind of the benefits more targeted to the hospital setting and the ED setting, but there's also other ones more generally speaking for the society. Having a better access to primary care has been demonstrated to reduce healthcare costs in general, because if patients are able to see their doctor easily, they will more likely see them early in their disease. If it's difficult to have access to your family doctor, maybe you'll wait a little bit more and the problem will become more severe and then end up in the ED setting or lead to hospitalizations that are more severe. So taking each medical issues earlier is in the long term saving for the healthcare system. The other aspect that we maybe the last that we don't think that much, but is very important from a personal, like from a patient's perspective, is the productivity. If you have to wait for 12, 18 hours in the ED to see a doctor, maybe you'll miss your entire day of work, maybe the day after too, because you're just too tired of this time spent at the hospital. So that means 2 days off maybe. If you're able to book an appointment with a family doctor, then maybe you'll be able to arrange your schedule around that appointment or miss just half a day. So those things are important from a personal perspective, but also from a societal perspective. If people are able to be, if medical issues are taken earlier and in less time for patients, it's just better for the economy in general. This concludes the portion of this presentation. Thank you very much. I don't know, Elliot, if you want to add a word here.
Yeah, just in terms of concluding, once again, we certainly appreciated everyone who attended today's webinar. And I see that the chat is lighting up, and we'll get to as many questions as possible over the next 10, 15 minutes. As a reminder, if you had opted in for follow-up email, you'll be receiving the economic impact assessment. But if you'd like to access it now, we can just scan the QR code. My contact information is at the bottom of the slide as well, and be happy to connect with you on any questions, or if you'd like to chat further, please don't hesitate to reach out.
Thank you very much. I will start the Q&A. There are so many. I'm going to start in the Q&A box. Are these costs specific to Quebec, or is it Canada-wide average?
let me just go back to be sure. They are Quebec specific.
Quebec specific.
This one comes from the RAMQ, and these ones are Quebec specific.
Thank you. For ED redirection, was the community taught about the project, or was there an increased number of patients presenting to ED but not being seen by ED, so they could get a primary care appointment sooner and be seen by a triage RN?
As far as I know, I'm not aware of any community efforts regarding the ED redirection process. So highlighting if it's available or if it's an option for patients. It really was at point of care. So in this context, patients who are presenting themselves to the emergency departments oftentimes have no other option. You know, they've tried other services, and part of why the program was established was because in Quebec, walk-in clinics would fill up first thing in the morning, and people weren't waiting or willing to wait until the end of the day or try again the next day. And so oftentimes you saw a large majority of patients showing up to the EDs. And I think I can answer the next question as well in terms of if they were able to book immediate appointments. Yes, this was true. So in the process of the ED, patients who presented themselves, they'd be triaged according to the protocols established by that healthcare institution. And the difference now is the triage nurse would have access to what we call a staff-assisted booking portal. So within this staff-assisted booking portal at point of care, they're able to view all of the available appointments for the ED redirection process in real time. So they'd be able to book an appointment, first available appointment or most convenient appointment, because that really depends on a patient preference. Because ultimately, the patient has, say, the final authority, the final decision making, whether they want the appointment or if they would prefer to wait at the emergency department. So as a patient, I would prefer to have the most available appointment or the quickest appointment, whether that's in 2, 3, 4 hours or within 24. I have the peace of mind that I've been triaged, I'm deemed less urgent, and that I'm going to see a care provider within a timely fashion. So the way it works is, we talked about the different processes and sort of the different buckets for the different initiatives. From a compensation perspective, Petal had no involvement in the incentives. So we supplied the technology to really enable those programs where the government incentivized clinics and physicians to open up slots within their availabilities to take on these different programs. So an example is, as an individual physician, I'm going to open up an hour every day for the ER redirection process, and I'm incentivized by government to have these availabilities. The same can be said for the primary care access point for unattached patients and timely access initiative, where I'm really making time in my calendar for these buckets or for these different programs that are being enabled by an underlying technology.
Thank you. The shifting of demand to family practice would represent an economic cost on them, correct?
It's more I think that the tool is just capturing the availability that was not easily filled before. So it's not necessarily, there's a pressure, there's an increased demand for family visit clinics, but it's the increase in pressure, it's basically the cost of those visits. It's taken into consideration in the economic model. I'm not sure if that answers the question, but yeah.
He also said, imagine that this has been asked already, but in case it hasn't, there were substantial declines in ED use due to COVID that were long lasting. Was this accounted for in your analysis or of the decline?
Yeah, the period was really after the COVID. It's possible that a portion of it was that patients are maybe think 2 times to to book an appointment, to present themselves to the ED. But this would not be possible if it's not possible for them to see their family doctor or a primary care physician elsewhere outside of the ED visit. Because otherwise, if patients have issues, they will present themselves to the ED visit. So the thought was that without those initiatives, the impact on ED would not have been the same. And the fact that we're using just 3/4 of the reduction in visits is kind of an approach also to take that aspect in consideration.
Have paramedic services been included in any of these initiatives, including paramedics and community paramedics, could really extend the effectiveness of this program? Sorry if this is not incorrect place to.
That's a really good question. And there's different use cases that we're currently exploring with our partners, paramedics being one of them, and pharmacy services as well. So what we've heard across the different jurisdictions across Canada is really how can we reduce the burden on frontline physicians within primary care? Part of that is expanding scopes for nurse practitioners, for pharmacists. So there's different use cases within primary care that we've been having discussions around. Because at the end of the day, we're still taking the same framework between supply and demand. And regardless of, the demand's always going to be there. If anything, it's going to keep on increasing because we have more complex patients. We have an aging population and we have population growth. So the demand's still going to go up. From the supply portion, historically primary care has been reserved to family practitioners. I grew up that way. My first instinct is to go see my family doctor. But now that you have expanded scopes for NPs, for pharmacists, for team-based care, the general population may not be aware of that. So these are additional measures to alleviate that burden on, family physicians. And, having a healthcare orchestration platform that has proven to manage that supply and demand only makes sense to extend it into other care settings. So whether that's within, as I mentioned, team-based care, NPs, pharmacists, but also other settings outside of primary care. So if we look at acute care, a big portion of ED wait times is attributed to bottlenecks within EDs and to bed blocking and ALCs. Is there a mechanism that can explore, we have, demand for beds in other care settings. We only have a limited amount of supply. Is there a use case that we can explore within the acute care setting to start resolving some of these bottlenecks? You can look at mental health as another area for exploration as well, given the rise in mental health consults. So its applicability is across the care spectrum. We started with primary care, but our team has had numerous discussions with various jurisdictions, exploring sort of what is feasible, what is next.
Can you elaborate on how all clinics across the province agreed to participate in data sharing?
That's a really great question. And I believe my colleague put a response in the chat, but I think it's important to talk about the partnership and how we were successful in Quebec. Petal's a technology organization, and we really needed the support of our government partners to help enable uptake of this transformative project. We can go to as many clinics as we want and ask, hey, do you want to participate? Do you want to participate? That's not really up to us to decide. So having a great partner in the Ministry of Health who held sessions with the FMOQ and with other key stakeholders to keep the associations informed to really help enable the uptake and why we're able to be so successful in having over 800 clinics. I think the partnership spoke for itself, both from a technology perspective and then from a program management perspective to generate uptake and to show the results that we've shown to date.
We have time for just maybe one or two more questions. Where do walk-in clinics feature into this? Are they also included in the system and in available appointments?
Yes, absolutely. So it's another demand or another supply point. So if clinics wanted to be a part of the program, they would work with their association. And, once again, sort of the healthcare orchestration piece is really taking those availabilities, those appointments from the EMRs, aggregating that information and making it available for patients. And it's not just making it available online, but through phone. So if a patient was able to call the clinic, they're able to see in real time what those availabilities are and provide that to a patient who's seeking care.
I'm going to scroll down a little bit because I do see that some of these questions have been answered. Are there nurses able to book immediate appointments for the redirected patients? Also, sorry, I'm losing my spot. How does the patient accept this redirection look like based on your experience?
So nurses, after the proper triage process, are able to book appointments for patients. So they're able to log in and see what appointments are available through the ER redirection program, maybe around the hospital, around the patient's home, or their preference. So that appointment length really depends on, what is available and the patient preference. At the end of the day, the patient has the ability to say no and say, I would rather wait in the emergency department. I am not certain whether we've collected data on, how many of those conversations resulted in redirections versus those staying within the hospital. But ultimately, patient safety is at the forefront of anything that we do within healthcare. So that decision ultimately lies with the patients themselves.
Thank you. So we're going to wrap up. What I always suggest is there are still a lot of questions. Is there a good place to have them reach out with their questions so that they can get answered?
Yes, absolutely. So my contact information is below. edesley@petalhealth.com. I'd be happy to answer any questions or schedule time. And please feel free to reach out. Our team of close to 400 at Petal, we work very closely together and collaboratively, and I'm sure we have a few people that have been experienced and that have been engaged throughout our 4 or 5 years on this project that are able to provide additional information and clarity.
Thank you. Can I get you to stop sharing your screen? Wonderful, thank you. While I've got everybody's attention, I'm going to launch a satisfaction poll. If I could get everybody to take a moment and just answer that, that would be lovely. I'll give it a second. And we're doing that. Okay, thank you very much. Okay. You'll see, sorry, all attendees will receive a short questionnaire immediately following this session. The QR code is on the screen if you'd like to scan it now. We do encourage you to take the 2 minutes to complete it and provide your feedback. This feedback does help us shape our programming. So we always want to bring that to you. Digital Health has launched. Digital Health has launched our community platform. I encourage you, our members, to log in and join the community platform. All members log in to start or join discussion. All industry showcase recordings are now located on the community platform. If you're not a member and interested in learning more, please reach out. I do appreciate, I thank you, Petal, for this informative presentation and for hosting this session. It is greatly appreciated. It is lovely to meet the two of you. Thank you so very much.
Thank you.
Thank you, everyone.
Have a lovely day, everyone.